Hello, my name is Larry Cahalin, and I'd like to thank the Cardiovascular and Pulmonary Section, the American Physical Therapy Association, for supporting the PACER project, the PACER presentations, and this presentation on respiratory muscle training. I am pleased today to be joined by Magno Formiga, a physical therapist from Brazil who has a vast knowledge base of inspiratory muscle performance in patients with COPD. You will be hearing from Magno later in this presentation. This course is intended for educational purposes and does not replace mentorship or consultation with more experienced cardiopulmonary or acute care colleagues. This content is current at the time of dissemination. However, evidence and science on COVID-19 is evolving rapidly and information is subject to change. Both Dr. Formiga and myself have been involved with respiratory muscle training, both clinically and from a research perspective, for the majority of our careers. Additionally, Dr. Cahalin and Formiga have no conflicts to report. The overall objective of this presentation is to make respiratory muscle training as practical as possible. To do so, we would like to describe respiratory muscle training and methods to test and train the respiratory muscles in patients who are most like those with COVID-19, thus patients with heart failure, COPD, and idiopathic pulmonary fibrosis. We would like to discuss potential concerns and benefits of respiratory muscle training in patients with COVID-19, and we would like to describe some of the work we have done in patients with the above diagnoses to highlight why respiratory muscle training may be helpful for patients with COVID-19. This slide shows the muscles of inspiration on the left and the muscles of expiration on the right. Respiratory muscle training can be targeted to the inspiratory muscles or the expiratory muscles, are both inspiratory and expiratory muscles. Respiratory muscle training is most often performed because of respiratory muscle weakness and dyspnea, poor respiratory muscle endurance and dyspnea, or impaired breathing and dyspnea. The patient with COVID-19 who has received mechanical ventilation is susceptible to having impairments in all of the above. Thus, for this patient population, and even those without mechanical ventilation, but with a diagnosis of COVID-19, respiratory muscle training may be indicated. Additional benefits of respiratory muscle training exist. One particular benefit is the influence it has upon the autonomic nervous system. I would like to ask each of you to examine the effect of respiratory muscle training or breathing exercises on the autonomic nervous system in two related experiments. In experiment 1, I would like you to please take your pulse for 30 seconds and determine the heart rate and if the pulse is regular or irregular. In experiment 2, please find your pulse again, and while palpating for 30 seconds, take 4 full deep breaths, inhaling and exhaling maximally, and determine the heart rate and if the pulse is regular or irregular. I will not wait for you to do that. We have other things to proceed to, but I would like you to do these experiments, please. And what you should find is the 4 full deep breaths are likely to decrease the heart rate and elicit a more irregular heart rate, thus heart rate variability, which we know is a good thing. Other benefits of respiratory muscle training include eliciting a gentle or profound cardiorespiratory training effect, depending upon the workload. Respiratory muscle training may elicit bronchodilation and the mobilization of secretions. It may decrease hypertension. It may improve insulin resistance and sensitivity. It may decrease inflammation, and it may improve the immune system. How might all of these things occur? Well, let's examine the biomechanics of breathing. The biomechanics of breathing are really related to the decrease in intrathoracic pressure. That decrease in intrathoracic pressure allows for ventilation to take place. When the diaphragm contracts, as we can see at the top of this slide, it compresses the abdominal contents. Compression of the abdominal contents increases intra-abdominal pressure. causing expansion of the lower rib cage. It causes the upward-outward motion of the lower ribs, a bucket handle motion, and the anterior-posterior motion of the upper ribs, the pump handle motion. All of these motions increase thoracic volume vertically and transversely. Thus, as the size of the thorax increases, the pressure within it decreases, and that decrease in intrathoracic pressure facilitates inspiration and venous return. This slide was very nicely described in the first of the PACER presentations on the pathophysiology of COVID-19 by Dr. Tepper. I would like to just highlight a few aspects below the gear system, which he beautifully described, and to, as we move from the right under ventilation to the left under muscle, highlight those things that are associated with COVID-19. The obstruction, the restriction, the chest wall, and the infiltrates that can occur that impair ventilation with COVID-19. And that interface between ventilation and circulation, thromboemboli, vasculitis, maybe pulmonary hypertension, under circulation, heart disease. In that interface between the circulation and muscle, hypertension, autonomic nervous system dysfunction, and as we look at the muscle, obesity and airflow obstruction. All these factors contribute to the difficult time COVID-19 patients have with the inhalation of oxygen and the movement of that oxygen to the mitochondria, to the far left of this diagram, and then the movement of carbon dioxide from the mitochondria through the muscle circulation and the lungs to then be exhaled into the atmosphere. This slide shows factors responsible for inspiratory muscle dysfunction in patients with COPD. Dr. Formiga put this together for his dissertation. The things I'd like to highlight include those that I believe also are found in patients with COVID-19. In the center of this top part of the slide, we see the lung and systemic inflammation that has gone awry in COPD and COVID-19, producing airway abnormalities and damage to lung tissue. As we move down to the COPD box, we see that there's an increase in the inspiratory muscle load and a decrease in inspiratory muscle capacity. Also, we find that there's increased airway resistance in the same box, increased respiratory drive, and impaired gas exchange. We also know that in the COVID-19 patient, aging, comorbidities, and inactivity can further contribute to the disorder and disease as well as inspiratory muscle dysfunction. All of these reasons, we believe, are reasons why patients with COPD and likely COVID-19 would benefit from inspiratory and expiratory respiratory muscle training. Keep in mind that COVID-19 also affects the heart and the heart's ability to pump. As we move through the series of events that take place during the cyclic cycle here, and a bit repetitive, you might say, during this cycle we have hopefully adequate filling and adequate removal or pumping of blood to the lungs, and that particular movement of blood from the lungs to the left ventricle to then allow blood to be moved to the periphery. If the heart is impaired, the contraction and the blood moving to the lungs and to the periphery may be impaired, which in many patients with COVID-19 seems to be a factor involved in this particular virus, and something that we should consider and think about when doing respiratory muscle training, as well as any other formal exercise. Again, the patient population that may be most like that patient with COVID-19 is the patient with heart failure, and the signs and symptoms of heart failure include dyspnea, fatigue, anxiety, tachypnea, a dilated heart, pulmonary edema, ascites, and poor inspiratory muscle strength and endurance. All of these things are reflected in this particular slide, and if you were to compare the person in this slide to one with COVID-19, you would probably see a very similar presentation to that particular patient. This slide shows the relationship of respiratory muscle weakness to dyspnea in patients with heart failure. The dyspnea index is in the center of this slide, and the dyspnea index is a measure to examine the number of activities a person can do before they become dyspneic. Thus, a higher value reflects less dyspnea. And what we see as we look to the right of this particular slide, we see the PE max, or the maximal expiratory pressure, and as we look to the left, the Pimax, or the maximal inspiratory pressure, the greater the pressures, the less dyspneic a person is, or you might say, the more activities they can do before they become dyspneic. Breathing in heart failure is characterized by a shallow tidal volume. The breath of each person is shallow. They have rapid respiratory rates, episodes of apnea, hyperpnea, hypopnea, Cheyne-Stokes breathing, stopping and starting, and oscillatory ventilation. When the person breathes with heart failure, it's not that dissimilar likely to the person with COVID-19 with these particular characteristics outlined. The movement of air, the oscillatory ventilation, the movement of air in and out of the lungs seems to oscillate as shown in this particular figure. We see the increase in ventilation marked by the blue arrow and the decrease in ventilation marked by the red arrow. This same type of ventilation may be present in patients with COVID-19. The ventilatory response to exercise in heart failure is shown in this slide. In patients with heart failure, and very likely in patients with COVID-19, there's a decrease in tidal volume, a decrease in peak oxygen consumption, and a decrease in end tidal carbon dioxide. There's an increase in ventilation, an increase in dead space ventilation, and an increase in ventilation to carbon dioxide production. Thus, the VE-VCO2 ratio and slope may be steeper. This slide shows the ventilatory response to exercise in heart failure. In the left corner of this particular figure, we see a legend with less than 12, 12 to 16, and greater than 16. Those values reflect the maximal oxygen consumption in milliliters per kilogram per minute in patients with heart failure. If the maximal oxygen consumption was less than 12, that individual is reflected by a dark filled-in circle. If it was 12 to 16, an open circle, and if the oxygen consumption was greater than 16, a dark filled-in square. Individuals who are normal, or who are normal reflected in this particular figure, have an open square. On the x-axis, we have ventilation with liters per minute. On the y-axis, tidal volume, milliliters per centimeter. And what we see as we further interrogate this figure is that patients with a very low level of oxygen consumption, less than 12, at the bottom part, circled in red, they actually have a low tidal volume and higher ventilation with a reduction in exercise capacity, stopping at about 50 liters per minute, compared to the patients, I should say, the normal population, where the individual has a greater tidal volume and a greater ventilation, as we can see circled in blue, and greater exercise tolerance. As we look upon the respiratory rate, which has been superimposed on this particular figure, we can see that the actual respiratory rate of the normal population is much lower at maximal exercise compared to the limited exercise done by the person with an oxygen consumption less than 12, with the circled area in red. The respiratory rate much greater and very likely reflects the same type of ventilatory response that we see in patients with COVID-19. This portion of the presentation will discuss respiratory muscle training methods and devices. Many methods and devices exist. This slide shows the different methods and devices, with the top method being a supine or semi-recumbent position that a person has assumed with weights upon the abdominal area. As the diaphragm descends in this position, the only way that it can descend is move that particular weight upward, providing a little bit of work as the diaphragm descends into a shortened, contracted position. This is the method that many of my colleagues and I used back in the day when we first started doing respiratory muscle training, and it does have an effect. It may not be as effective in patients with COVID-19, especially if they are suffering and may benefit from a more prone position. Inspiratory muscle training devices can be used. One is shown in the middle of this particular slide, and another is a combined inspiratory and expiratory muscle training device. This slide shows the spring-loaded threshold respiratory muscle training devices that are most currently used. The threshold inspiratory muscle trainer is on the left, and the POWERbreathe inspiratory muscle trainer is on the right. The threshold inspiratory muscle trainer has numbers on the white piece of material that can be seen through the clear plastic container for this device. Those numbers represent centimeters of water, which is the unit of measure obtained when we measure respiratory muscle strength. The resistance from the spring can be increased or decreased by simply turning that area where the numbers are in one way or another to increase or decrease the resistance of the spring upon a piece of plastic that the person now must overcome that threshold resistance to inspire, especially when wearing a nose clip. In the same description or figure for the threshold inspiratory muscle trainer, we see that this particular training device can also have an oxygen port attached to it, and then the mouthpiece placed into that oxygen port that you can hopefully see to the left of the larger diagram, from which then an O2 tubing can be attached and a person can be administered oxygen while doing inspiratory muscle training. The POWERbreathe inspiratory muscle trainer on the right is the same type of threshold loading device. There are no numbers on this particular device that you can actually see, but there are actual levels that can be dialed in. And depending upon the POWERbreathe inspiratory muscle training device, whether light, medium, or heavy, there are certain levels that certainly reflect and represent centimeters of water and the workload that the person will experience. These are the two probably most common forms of inspiratory and in some cases expiratory muscle training. Flow-dependent respiratory muscle training devices also exist. The PFlex is on the left, the DHD Portex Smith's Med DHD device in the middle, and we see with these devices, these two, the PFlex and the DHD, there's a hole within a piece of plastic that a person must inhale. Thus, the effect or the challenge placed upon the respiratory muscles is dependent upon the diameter of the hole. The smaller the hole, the more difficult it is to inspire, and likely the greater resistance that will be provided or applied to that particular inspiratory effort. If we think about this particular type of training, it's not that dissimilar from the use of straws. There has not been much literature that has examined the use of straws, but when we think about respiratory muscle training and the devices that I've already discussed, one of the things that need to be entertained is the fact of aerosolization, the aerosol that may be developed and is a problem with COVID-19, as well as the fact that we do not want to have contamination from the use of these types of devices. And it may be that straws may provide a very inexpensive manner by which we can actually provide this same type of training, this flow-dependent training, using a straw with a larger or greater diameter, making it easier, or a smaller diameter, a little bit more difficult to inhale through, like the small holes in the PFlex or the DHD devices. This slide shows the threshold compared to the POWERbreathe, another type of inspiratory muscle training device, the POWERbreathe KH1, which is shown on the right, the threshold you can see on the left. Both forms of inspiratory muscle training have their advantages and disadvantages. If we look at several characteristics that are presented in the figures above these particular devices, we can see that the area under the curve of inspiration with the threshold device is less than that when we compare it to the POWERbreathe KH1, which we would call tapered flow resisted loading, TFRL. We can also identify other differences. In fact, the pressure that's generated throughout is different with the TFRL compared to the mechanical threshold loading of the threshold. We see more of a square box type of training with the threshold compared to a peak, and then a little bit of resistance pressure as it continues to decrease throughout inspiration. We also see the volume of air presented. Here it's greater with the POWERbreathe compared to the threshold, where the volume of air inhaled is less. Both devices have their advantages. The threshold is cheaper. The POWERbreathe is a bit more expensive. It's a device which would require a filter unless a person does have one that is then for use, single patient use, like that which might be required for a person with COVID-19. In 2003, some colleagues of mine and I presented at the World Confederation for Physical Therapy in Barcelona, Spain, and the person on the far right, without the PhD, was smart enough to invent the test of incremental respiratory endurance, the TIRE, which is shown, the initial device which he invented is shown on the left of this particular slide. It involved a person holding the device, wearing a nose piece, a nose clip, that then required them to point the device towards the pod that is in the left-hand corner of this screen here. That particular person then saw their inspiratory effort projected and presented on a computer screen that then allowed them to have the information and the biofeedback for their inspiratory effort. My colleagues and I in Boston were able to get several research grants, and we were able to take this larger device on the left and develop it and construct it into a much smaller device that then, through Bluetooth technology, allowed the same information presented on the computer screen here to be presented on an iPhone or an iPad or any other type of device through Bluetooth technology. And with the TIRE, we are able to obtain some measures that are not available with other methods. The maximal inspiratory pressure, the sustained maximal inspiratory pressure, or the SMIP, and the inspiratory duration, the ID, presented in this particular slide. If we look at this slide, we can see the maximal inspiratory pressure at about 120 centimeters of water, the sustained maximal inspiratory pressure, or the SMIP, which is a unit of measure in pressure time units at about 493. It's the area under the curve reflected during inspiration, and thus it represents or reflects the work of each inspiration. From this same type of device, we can also obtain the inspiratory duration, which we see here at about 10.2 seconds. This is a real in-series inspiratory effort that is obtained through this particular device. You can either accept or reject the test, and then from that particular test, you have information presented on the screen. The information that is presented will then allow the person to train at a particular level. And you can actually dial into the app and to the device what percent of the maximal inspiratory pressure and the sustained maximal inspiratory pressure you would like the person to train at, whether it's at 20, 40, 60, or 80% or more of that particular individual's maximal inspiratory pressure and sustained maximal inspiratory pressure. The training with the TIRE, as with the POWERbreathe, is different compared to the threshold inspiratory muscle training device. The threshold, again, presents more of a square wave pattern of training, while the TIRE presents a picture very similar to the POWERbreathe. The TIRE and the POWERbreathe are both more expensive devices compared to the threshold, but they appear to provide a little bit more information and a whole different training load that allows a person, perhaps in some cases, to have more beneficial effects of training compared to possibly this more square wave pattern presented with the threshold. Respiratory muscle training devices are or have been developed for both inspiratory and expiratory muscle training. We see the devices that are listed here, and in the right-hand corner, we see the threshold inspiratory muscle trainer, which traditionally is used for inspiratory training, but my colleagues and I used to actually just take a mouthpiece, place it on the distal end of the normal inspiratory muscle trainer, and then you'd have both an inspiratory and expiratory muscle training device. Again, it's important to keep in mind that during inspiratory and expiratory muscle training, Most individuals should be wearing a nose clip to really elicit the changes we hope to achieve with both inspiratory and expiratory muscle training. There are a lot of different respiratory muscle training devices on the market. This particular article outlines a review of those particular respiratory muscle training devices and provides a lot of information in regards to the load and the adequacy of the load. Is it portable? Is it usable? Is there an adequate mouthpiece for a person to use and seal? Is it possible to do home training? Is it easy, fast? Does it allow both inspiratory and expiratory training? And what about the cost? These are all found in this particular article, and I think hopefully this particular table provides you with some information about those, some of which we have discussed already. What about incentive spirometry? A number of clinicians around the country have reported that many of the patients they've been working with COVID-19 have been provided incentive spirometers. And they were wondering whether, in fact, the incentive spirometer can provide some form of training for these individuals with COVID-19. Well, this particular paper looked at the control group, which really did no training with incentive spirometer and just received normal standard care, while other individuals in the study did training with an incentive spirometer or the threshold inspiratory muscle trainer. And what we see from this data is that the incentive spirometer did elicit some changes in the Pimax, which is shown here on the y-axis. It increased, but not as great as that obtained or observed with threshold inspiratory muscle training. And I think this is something that if you do not have a training device, an incentive spirometer may give a biofeedback and a little bit of inspiratory training for those individuals with COVID-19, especially if they have this device in their room that they can then hopefully take home. I found this article in 2004 published by a Toronto group who do a lot of work with inspiratory testing and training, and I had a really hard time trying to really get and show you a diagram or a figure that they have with this incentive spirometer that actually has an inspiratory muscle trainer inserted in line with it. So what I did is took one of our incentive spirometers and I took the DHD device that we've already talked about. Again, these devices have different sized holes that then can be placed in series with the tubing for the incentive spirometer and with this particular setup that as we look at this, you can hopefully see the red plastic piece in series here, placed within this particular plastic piece, the mouthpiece here, and there's a one-way valve that allows the person to inspire and to hopefully have biofeedback while also getting a little bit of inspiratory muscle training. Again, this is the smallest, the most narrow opening, giving the person a greater workload compared to a diameter that's greater where there's less of a work imposed upon the inspiratory muscles. The information for this particular setup can be found here, and it's about $7 to $7.50 for each one, depending upon what you buy and how you buy it. But for the most part, this type of setup has been used with the testing of respiratory muscles, which we'll get into later. But it's something that might be available for single patient use if you have access to the DHD system and you want to put it in series with incentive spirometry. Other methods to train the respiratory muscles do exist, as I've already mentioned, the supine or semi-recumbent position with weights on the abdomen. But with this patient population, when they're discharged even, or in the hospital after mechanical ventilation, the prone position might be the best position in which to do inspiratory muscle training with any of the devices that we've talked about. Other methods for respiratory muscle training that exist may include straps or belts wrapped around the thorax to facilitate a little bit of resistance, or simply maybe when working with patients, manual facilitation with inspiratory cues and manual resistance, during which if a person sniffs through the nose, they are most likely to elicit the sniff reflex that will elicit the diaphragm's contraction and allow for greater inspiratory muscle training. So how do we traditionally train the respiratory muscles? Well, typically at a specific percentage of the maximal inspiratory pressure or maximal expiratory pressure. Keep in mind, I haven't really mentioned this yet, but when we measure the maximal inspiratory pressure. It's a negative pressure, even though we may not see it on the devices that we're using to measure. And the maximal expiratory pressure is a positive pressure. So with this particular Magnehelic manometer, if you were to take this mouthpiece, put it in your mouth, wear the nose clip, and we move this particular setting to inhale, the person, when inhaling, you or I, our inhalation at max would likely be around 100 centimeters of water. And if we were to train that person with inspiratory training, we could set, let's just say, that person at 50% of their maximal pressure. Again, we said was 100 centimeters of water. So we'll set them at 50 centimeters of water. And in fact, we can use this same device. Person puts this in their mouth, they wear the nose clip, and they could do inspiratory efforts up to 50 centimeters of water, and that could be their inspiratory muscle training period for how many breaths we'd like them to use. The same would be true for expiratory training. We would obtain a positive pressure, a maximal expiratory pressure. We'd move this particular dial to exhale. We'd have the person wear the nose clip, have them put this mouthpiece in their mouth, and we'd have them take a full deep breath and exhale into the mouthpiece with hopefully good seal. And we would probably find a maximal expiratory pressure of about 150 centimeters of water. We could do expiratory training at a particular percentage as well, but expiratory training is really hard, and it's difficult to achieve the higher pressures that we sometimes find with inspiratory training. Thus, for the most part, you'll probably do expiratory training at maybe 10 to 20, maybe 30% of the person's maximal expiratory pressure. Other methods to measure inspiratory and expiratory pressure include handheld devices like this, which provide a digital display. As well, we can also measure the pressure from the nares in the nose and get a digital measure and see what the person's inspiratory and or expiratory pressures are. We can also use a sphygmomanometer, a blood pressure taking device, which in fact my colleagues and I have done. We've tested, we've looked at, and we find that although the blood pressure cuff is measuring blood pressure, a positive pressure, when we inflate this, we have a positive pressure reading. The valve actually moves backwards if we inspire through it, and it provides us with a pressure in centimeters of water, and that particular pressure is pretty much reflected, almost identical to that which we've obtained with Magnehelic gauges and pressure transducers, such that we see a perfect, almost perfect correlation in this particular slide. What I've shown here in this slide is the setup of the same type of device that was shown for the most part for testing in slide number 34. You can take a sphygmomanometer pressure gauge, just take the rubber tubing off, take this particular setup that I described earlier in slide 34, attach the oxygen tubing with it to this particular part of the sphygmomanometer, and the mouthpiece would be here, from which you could hopefully obtain in a single patient a maximal inspiratory and expiratory pressure. Those pressures then, again, inspiratory would move backwards. Keep in mind that there's a 320, if we were to measure blood pressure, that much value here. So we'd have to, again, keep in mind this is going to move backwards. 20 centimeters of water when we get to 300, 40 to 280, 60 to 260, and 80 to 240. And hopefully that makes sense if we think about that. Again, when we think about a sphygmomanometer and blood pressure readings, it's always in, for the most part, millimeters of mercury. We can simply convert the millimeters of mercury to centimeters of water by multiplying millimeters of mercury by 1.36. And when we do that, we can then, if we use a threshold training device, we can actually set this device at a particular percentage of that maximal inspiratory or expiratory pressure that we would see on this particular manometer, again, using a nose clip. The thing of concern, again, is with inspiratory muscle testing and training, not all filters were created equal. And some filters may fit or may not fit upon this type of device. As you can see, they are separate, so they did not fit. And it's important to keep this in mind if we're going to use this for multiple patients, that we have an adequate filter. We also know that some filters, if we achieve a certain pressure, whether it's negative or positive, that filter will no longer capture the particles that it's supposed to capture. So please keep this in mind, and single patient use seems most appropriate for these types of devices, which could also be, again, a training device for an individual with COVID-19. What about respiratory muscle endurance? Well, as I described earlier, if we wanted to train with this device, we could actually find a person's maximal pressure. Let's just say the maximal inspiratory pressure is 100 centimeters of water. We wanted to train them at 50%. Well, we could also do an endurance test. We could just see when the person is first being tested at baseline with us, what is this person's respiratory muscle endurance? Well, let's set them at, let's say, 50% of their max, 50 centimeters of water. And let's see how many inspirations they can take that allows them to achieve or exceed this particular 50 centimeters of water. When they fail and fall below it, whether we count the number of inspirations or we count the time that a person does this particular type of endurance test, we have an outcome measure of respiratory muscle endurance. What is respiratory muscle training? Well, it's targeted inspiratory or expiratory muscle training, or combined inspiratory or expiratory muscle training. I believe that the prone position may be best for this patient population to achieve optimal ventilation to perfusion matching and to also hopefully elicit greater change to the individual in this position. If we think about inspiration in this prone position, there is now going to be also a resistance to their inspiratory effort. They're laying on their stomach, and as the diaphragm descends, it will have to work against that particular body position and the particular force of that particular, whether it's a bed, a plinth, whatever it is that the person is lying upon in a prone position. Do we train for strength, endurance, power, work, or some combination? I think for patients with COVID-19, we probably have to train for all of the above, and with proper testing and observation at certain points in time, we hopefully can achieve the best for the patients with COVID-19 when it pertains to their strength, endurance, power, work, and combination of the above. This particular slide shows breathing exercises and inspiratory muscle training in patients with heart failure. As you can see from this particular circled area, the threshold inspiratory muscle training device was used the most in these particular studies in patients with heart failure, and the range seems to be from about 20% to about 60% of the maximal inspiratory pressure for different durations and for different time periods that the person may train either on a daily basis or a certain number of days per week. The study measurements are in the center part of this slide and the study outcomes. What we see for the most part is there is an improvement in many of the pathophysiologic manifestations of heart failure in this patient population. And I think if inspiratory muscle training were applied in the same manner with patients with COVID-19, that you likely would find some of the same improvements in these patients in some of these parameters, and maybe most of them, if not all of them. This also shows the use of a sphygmomanometer with both threshold inspiratory muscle training and inspiratory muscle training using the P-flex. When a patient gets biofeedback, they get a little bit of positive reinforcement about what they're doing. And the same type of positive reinforcement or positive satisfaction from this biofeedback can be provided when doing threshold or P-flex training, when the oxygen port might be attached to a sphygmomanometer if the person does not need supplemental oxygen. Because again, the person may be using the nose clip that would then require them to inhale if they need oxygen, or to measure the pressures in the biofeedback through this type of training. This particular slide shows breathing exercises and inspiratory muscle training in heart failure. For the most part, you see the threshold again is most commonly used, but the tire is shown in several of these particular studies, and we find improvements in the first row of maximal inspiratory pressure, sustained maximal pressure, pulmonary function test, peak oxygen consumption, 6-minute walk test, dyspnea, and TNF-alpha receptor change. These seem to suggest that some of the things I alluded to earlier may improve and allow for the patient with COVID-19 to have the same types of improvements, perhaps, with inspiratory muscle training and breathing exercises. This slide shows just the effect of slowed breathing exercises in patients with heart failure. The mode of exercise or inspiratory muscle training was in the first two studies, yogic breathing techniques, where individuals breathed at 6 breaths per minute for about 60 minutes daily, focusing on thoracic expansion and diaphragmatic breathing exercises. The improvements can be seen in the study outcomes: respiratory rate, oxygen saturation, exercise duration, peak oxygen consumption, ventilation, and dyspnea. Thus, all of those things that we talked about earlier in this presentation seem to be improved simply with slowing the respiratory rate down. The same may be true here in patients with COVID-19, but we need to look at this carefully, and while doing this, monitor oxygen saturation. And in fact, through all inspiratory training and or expiratory training, it's probably very important to monitor all the things that we see listed here, in particular respiratory rate and oxygen saturation. Device-guided paced breathing was also performed in 2 of these studies, and we found improvements in many of the same factors and the same indices mentioned above. As we've already mentioned, there are additional benefits of respiratory muscle training, and what I'd like to do is talk about some of them just briefly in the next few slides. This particular study looked at the effects of inspiratory muscle training upon the cardiovascular system. It was a systematic review and a meta-analysis. The patient population shown in the table below included individuals with chronic kidney disease, older healthy individuals, healthy women, hypertensive individuals, people with metabolic syndrome, chronic heart failure, obstructive sleep apnea, older healthy individuals, patients with chronic heart failure, and individuals with diabetes. Thus, this patient population in some manner reflects that patient population with COVID-19. What we see from this particular data is that with moderate to high intensity inspiratory muscle training, there was a near significant effect upon diastolic blood pressure. And with moderate to high intensity training, we found a significant effect upon lowering heart rate and upon inducing or eliciting heart rate variability that we talked about earlier when you did your experiment 1 and experiment 2. This slide shows the acute effects of inspiratory muscle training in patients with heart failure, and what it shows essentially is, as we move from the left to the right, the effect upon the Borg rate of perceived exertion. The next series of figures show the heart rate behavior, the stroke volume behavior in figure 3, and in figure 4, the cardiac output. And what we see is in the initial figure 7, the Borg rate of perceived exertion during the placebo effect, then at 30% of maximal pressure and 60%, we see a significant increase in the Borg gradient of perceived exertion. We also see, with 15 minutes of breathing at these same intensities, an increase in heart rate that's significant. We also find that there's a decrease in stroke volume at 30%, but an increase in stroke volume at 60% of maximal inspiratory pressure during 15 minutes of breathing. All of these were done randomly. And what we find here is a significant increase in cardiac output in these patients with heart failure at 60% of maximal inspiratory pressure during 15 minutes of inspiratory muscle training. So these benefits may be seen also in patients with COVID-19, but again, needs to carefully be examined in the patient population with whom you might be working. The figure in the bottom shows a scatter plot of individuals and shows that people with greater maximal inspiratory pressures on the y-axis have greater levels of cardiac output at baseline. This slide shows the maximal inspiratory pressure, the Pimax, and the inspiratory load to pulmonary artery relationship. I'd like you first to please look at the table here, which lists the New York Heart Association classifications. New York Heart Class 1, individuals barely feeling the effects of a disease. They're pretty active and able individuals, compared to New York Heart Class 4, where people are sedentary. They're unable to do physical activity because they are limited because of dyspnea, shortness of breath, angina, whatever it may be. When we look at this patient population with New York Heart Class 4 classification, we see the Pimax as a percent of predicted is significantly lower than the New York Heart Class 1 and other classes. The pulmonary artery pressure of this Class 4 group is significantly greater than that in the other classes. The pulmonary vascular resistance is also significantly greater, as is the transpulmonary gradient. So those patients, many of those with COVID-19, likely have a presentation like this. And it's important for us to think about in the way that it relates to the pulmonary vasculature, the pulmonary pressure, the cardiovascular performance, and what we ask our patients to do. The scatter plots that are shown here in this particular slide, in the first scatter plot below the table, we see on the x-axis pulmonary artery pressure, the mean in millimeters of mercury, as it relates to Pimax. The greater the pulmonary artery pressure, we see a lower maximal inspiratory pressure. The same is true for pulmonary vascular resistance. The greater the pulmonary vascular resistance, the lower the maximal inspiratory pressure. And what we find here in this lower to the right-hand corner of the slide scatter plot is the higher the pulmonary artery pressure, the more work, the greater the load on the inspiratory muscles, reflected by this particular index in this measure that's shown here. An important thing to comment that my colleagues and I have observed is that these first two studies were mentioned earlier in the breathing exercises for patients with pulmonary hypertension and heart failure. We see that these particular breathing exercises were able to decrease the pulmonary artery pressure, the systolic pressure, while this particular study, which was a combination of aerobic exercise with a few breathing exercises, did not lower the pulmonary artery pressure. We also find below this particular figure the peak oxygen consumption improvements that occurred with respiratory muscle training alone, similar to and maybe even exceeding that from aerobic training. Therefore, I believe patients with COVID-19 may have very similar effects from just simply breathing exercises, improving maybe the pulmonary artery pressure if it's elevated, and improving oxygen consumption. This slide shows the acute effect of inspiratory muscle training on glucose. What we see here is that a load of 60% of the person's maximal inspiratory pressure significantly decreases glucose level during the 15 minutes of breathing at 60% of the maximal inspiratory pressure. Likewise, for 30 minutes after, we find a decrease in the glucose level that is below that of a load that's been applied at about 2% of the person's maximal inspiratory pressure. Thus, patients with COVID-19 who have problems with insulin sensitivity, responsiveness, and or who have diabetes may benefit also from inspiratory muscle training. This particular slide shows the effects of inspiratory muscle training and insulin sensitivity. It shows that in an experimental group who did daily threshold inspiratory muscle training for 30 minutes at 40% of the maximal inspiratory pressure for 12 weeks, compared to a control group which did the same type of training, but the resistance, the spring was removed from the inner part of the device. There's no spring, and we find even with the training, there's some improvement in the control group compared to the experimental group. And the experimental group had a greater significant overall increase compared to the control group after inspiratory muscle training in the way it's been described above. We also find that the experimental group had a significant decrease in their levels of insulin as a result of this particular training after the 12-week study. And the homeostatic model assessment for insulin resistance also shown to be significantly lower in individuals with inspiratory muscle training performed in the manner described. Patients with idiopathic pulmonary fibrosis very likely reflect a population not that dissimilar to that with COVID-19. This particular study shows the effect of aerobic and breathing exercises in patients with idiopathic pulmonary fibrosis. And what we see here, when aerobic exercise was combined with inspiratory muscle training or breathing exercises, there seemed to be a little greater effect upon those particular individuals and the effect that we find upon this particular individual group of patients. Thus, for patients with COVID-19, this type of training may be beneficial when combined with aerobic resistance training. This was another study published in Poland. It showed after 12 weeks of rehab, there was a significant decrease in dyspnea, 6-minute walk test distance, increase in maximal inspiratory pressure, and a decrease in dyspnea, and an improvement in quality of life in those compared to baseline values when they were doing aerobic exercise combined with general body conditioning. and inspiratory muscle training. When we looked at the control group who performed only body conditioning, we found that there were some improvements in the distance walked during the 6-minute walk test and an improvement in quality of life, but there was no improvement in the sensation of dyspnea. During the 6-minute walk test, the maximal inspiratory pressure was not noted to be improved either. So these results suggest that inspiratory muscle training for patients with idiopathic pulmonary fibrosis, again, a patient population probably very similar to that patient with COVID-19, might be very beneficial. Additional issues regarding respiratory muscle training include, as I mentioned briefly before, sniffing through the nose to elicit the diaphragm and the sniff reflex. Possibly respiratory muscle training with straws, an easy, convenient way to possibly train the inspiratory muscles and maybe even expiratory muscles because of the diameter that might be used. But again, we need to think about this in particular because of the fact that not all filters were created equal. We've observed problems with people who have vocal cord or fold problems. If they demonstrate snorting sounds during inspiratory muscle training, they seem to not do as well as those who do not. And there has been literature describing this and other things related to this type of breathing technique that might be useful for individuals who might have problems such as that, who may experience vocal cord or fold problems. Again, perhaps a problem in the COVID-19 patient population. Again, the role of expiratory muscle training needs to be further examined. Increasing intrathoracic pressure may have a positive pressure-like ventilation effect and may improve cardiovascular performance, which may be a good thing for patients. Take it away, Dr. Magno Formiga.
Hi, Magno Formiga speaking here. I'll spend the last portion of our presentation time discussing two specific factors that will likely contribute to respiratory muscle dysfunction in COVID-19. We'll talk about how the infection-induced inflammatory response might have a direct and negative impact on the respiratory musculature. And then, even though the PACER project is about post-acute management of this population, I'll also briefly discuss respiratory muscle weakness as a consequence of prolonged mechanical ventilation due to COVID-19 and what we can do as PTs to try to prevent or at least minimize that issue within the ICU. So here's a paper we published early last year, which investigated whether systemic inflammation was related to inspiratory muscle impairment in COPD. To do so, we used the TIRE method to assess the inspiratory muscle performance of 53 subjects with mild to very severe airflow obstruction, which provided us with measures of maximal and sustained maximal inspiratory pressure, as well as inspiratory duration, which are measures that were discussed by Dr. Cahalin earlier in the presentation. And then, once we obtained that information, we sent the subjects to a lab so they could undergo blood sampling for 23 inflammatory markers, including acute phase proteins, cytokines, and adipokines. All of these markers you're seeing here were obtained blinded from the respiratory muscle assessment, and 3 of them caught our attention. Levels of C-reactive protein, CRP, cystatin C, and serum amyloid A, SAA, were significantly and inversely associated with how well their inspiratory musculature was functioning. Here are the scatter plots with the observed associations, and you can see at the top that the greater the CRP, cystatin C, and SAA, the weaker their inspiratory muscles were, as reflected by lower maximal inspiratory pressure values. Likewise, the greater the inflammation, the more reduced their single breath work capacity was, reflected by decreased SMIP values. Additionally, when we grouped patients based upon whether they had what was defined as inspiratory muscle weakness or not, we noticed that the subjects whose inspiratory muscles were weak had significantly larger amounts of inflammatory markers in their blood when compared to those with more intact inspiratory muscles. We wanted to make sense of these findings, so we went back to the literature, and of course, it's not news that inflammatory markers have been hypothesized to play a role in muscle impairment. Even though the causal pathway leading from inflammation to muscle dysfunction is yet to be fully explained, it is suggested that inflammatory markers may cause a decline of functioning through the catabolic effects of these markers on muscle. More specifically, CRP itself was recently found to influence muscle mass and muscle cell size while having the ability to reduce muscle protein synthesis. Likewise, SAA, which was the other marker linked to inspiratory muscle dysfunction in our study, has been shown to promote muscle wasting and may therefore be implicated in the pathology of skeletal muscle atrophy. So what exactly is the point here? Why should we be concerned? Well, a quick PubMed search will show you that there is already enough evidence that CRP, SAA, and other inflammatory markers are considerably elevated in COVID-19. Every single day a new paper is published, preprints are made available on this topic, and we should expect that on top of the inflammation which is already present in some pathologies, these patients with COVID-19 will face an added infection-induced inflammation that has the potential to impact their respiratory muscles through both direct and indirect mechanisms. Of course, we currently don't have any evidence on the impact of the COVID-19 inflammation in the respiratory muscles, but we should all be ready to manage a potential increase in the prevalence of respiratory muscle weakness, which might exist partially due to that. Now, let's talk about that portion of the population who gets infected by COVID-19 and ends up in an ICU. Not only will their respiratory muscles be impacted by the inflammation itself that we just talked about, but also by other factors such as mechanical unloading. We know that it only takes a few days of controlled mechanical ventilation in ICU patients for the force generating capacity of the diaphragm to be reduced significantly. That musculature is really not working, especially in more controlled ventilator modes. No wonder we have the so-called ventilator-induced diaphragmatic dysfunction being discussed all over specific literature for years now. We know that the longer they stay in the ICU, the more profound the respiratory muscle wasting will be. Unfortunately, accurate data on the duration of ventilation for subjects with COVID-19 are limited, but a few studies like this one, with a large sample size from Italy, suggest prolonged mechanical ventilation for 2 weeks. The good news is, we can help them. If you are a PT working within the ICU, know that there are ways we can try to at least minimize that issue. The last meta-analysis on the effects of IMT in critically ill subjects was published 2 years ago and found positive results. In randomized controlled trials, IMT was associated with a significant increase in both MIP and MAP from baseline compared with control. This forest plot here shows that the increase in MIP after IMT was observed regardless of training choice of strength or endurance. There were also significant effects of IMT when it comes to reducing the duration of ventilation as well as the duration of weaning, which are very promising findings. The authors conclude their meta-analysis suggesting that IMT is feasible, safe, and well tolerated in mechanically ventilated patients, which is great. But there are a few things that we need to be super careful about when it comes to our current COVID-19 situation. No study to date has been published on the effects or even experience of applying IMT in subjects affected with COVID-19 who are intubated. To the best of our knowledge, there is currently only one trial listed on clinicaltrials.gov that has IMT as part of their intervention in patients with COVID-19 who are receiving mechanical ventilation. The trial will be conducted in Italy, but they are not yet recruiting. And one funny thing about their trial description is that they mentioned they will apply what was defined as cautious IMT. Even though they did not give any further details on what they mean by cautious, I completely understood their concern. We are talking about a rather infectious disease with patients known to be unstable in the ICU, so cautious administration of IMT is for sure needed. A variety of IMT techniques could be used, from the use of IMT devices to ventilator trigger threshold adjustment, but safety precautions must be observed. If you are to use an IMT device, placing an efficient barrier filter between the patient and the device is a must-do. Devices must ideally be restricted to individual use only. but if you don't have the resources, devices should be decontaminated, cleaned, and disinfected before being shared. Now, keep in mind that there are several factors to consider in determining whether IMT is appropriate for an ICU patient. Here's a figure that summarizes these factors well. Of course, the patients must be alert, cooperative, so that they can follow your instructions. It's very important to always explain the procedures and make sure the patients understand why we are using IMT and how such technique can help them. They should not be in need of high PEEP or FiO2 levels. They should be pretty calm, stable, with good respiratory rate, and of course, able to trigger spontaneous breaths in case they are still on the vent. Again, with this presentation, I just wanted to give you a very brief but important overview of how inflammation and also mechanical ventilation might negatively impact the respiratory muscles of our COVID-19 patients before they even get to our post-acute settings. Based upon your clinical judgment, if you believe a patient with COVID-19 might benefit from IMT, please remember we should be very careful when applying it, regardless of IMT technique or device you choose to use, and always take appropriate measures to prevent virus transmission. Thanks, and now back to Dr. Cahalin.
Thank you, Magno. And a big, bold thank you for listening to and viewing this rather long presentation. And thanks again to the Cardiovascular and Pulmonary Section and the American Physical Therapy Association for inviting myself and Magno to do this presentation on respiratory muscle training for patients afflicted with COVID-19.